Good morning, everyone, and welcome to the first day of our hybrid 2023 symposium. We are very excited to have you all here. We'll give everyone just a moment to get tucked into their virtual space. As I see a couple more people are joining from the waiting room. And Evelyn, do you have the master slides you could pop back up just because we have that little bit, and then we'll let Amy take over? Great. So I know many of you, but not all of you. So thank you for those of you who are new that are joining. I am Kelly Wackich. I'm a pediatric hematologist from the University of Michigan, and I'm here with Melissa Rose, if you want to say hi, and then Evelyn to introduce themselves.
Good morning. I'm Melissa Rose from Nationwide Children's, and have the pleasure of co-hosting this symposium this year.
And hello, I'm Evelyn Arguro-Castritis, and I'm with A Race for Immunology, and I'm excited to be co-hosting the patient education session today, Wednesday, the first day of the NICER Symposium. And you may have gotten a lot of emails from me recently, so I just wanted to let you know that please reach out to me for any questions along the way with the symposium, and we look forward to connecting with all of you virtually over the next 2 days, hybrid with those not attending in person and in person. So thank you for being here.
And this session in particular is put on as a collaboration between Race for Immunology and NICER. So we wanted to take a minute, for those of you who weren't familiar with NICER, since this is more patient-directed, to make sure that you had a brief overview of NICER and what it entails. Can you just advance them, Evelyn, do you mind? So NICER is an acronym. It stands for the North American Immunohematology Clinical and Education Research Consortium, so hence NICER. The mission of the consortium is really to provide a collaborative, multi-specialty environment. So you will see not just hematologists, but also rheumatologists, allergists, genetics, ID, rheumatology, et cetera, here to help advance the education, clinical care, and research involving both pediatric and adult patients with immunohematologic disorders. And we're really focusing on that intersection of immunology and hematology. We have three main aims to enhance the communication between subspecialties, which you'll see throughout the symposium platform, provide immunoheme educational opportunities, and today's a great example, as well as ultimately leveraging a platform for cooperative research studies. The consortium is built with many of our colleagues and institutions around the country. We've grown quite a lot, Melissa, since we originally started out, and now are 20 strong with a signed memorandum of understanding. Hopefully there is one near you, but if there's not and you're inspired to join NICER to become more active, we encourage you to reach out to us as we have many roles and many friends to make. On our website, you'll see this particular graphic, which highlights our approach to recruiting both providers, whether that's as an institutional member or an individual member who are interested in the clinical immunology space, patients. We have lots of activities for patients and a great relationship with Race for Immunology. And then, of course, our partners in industry also help us build and edify our research platform and challenge us with new ideas. So we'd love to hear from all of you. In terms of the big meeting, our organizational team has put through perhaps an ambitious adventure, but on Wednesday, this is the session Mischief One of a Kind. We'll be understanding the impact of the care team on rare disease patient care throughout the morning, and ending with a lunch and learn about breaking bad news or serious discussions in rare disease. On Thursday, we'll transition into a forest of wild possibilities, really talking about the common IEI presentations in the primary care setting, since that's where most of the patients start their evaluation. And then in the evening, An Ocean to Travel will kick off the hybrid symposium in Pittsburgh with an introduction to Pittsburgh itself and examining the critical role of multi-specialty collaboration. Friday, we'll let some of the chaos reign with the keynote speakers and let the wild rumpus start and really think about the different perspectives on the interplay of the immune system and cytopenias. And then in the afternoon, we'll have a lot of learning opportunities far away across the world. We'll meet new friends, speed mentoring, diversity panel. And then on Saturday, we'll close with Into the Night of the Marrow, where we'll take a deep dive into a pathology viewpoint, looking at the hematopoietic manifestations of immune dysregulation. But without further ado, let's get started with Mischief, One of a Kind. And so this Wednesday, we will start with Amy Chait and hearing about the nursing perspective and nursing partnership. Then we will transition to a panel discussion, partnering with the care team and learn about the different roles of each team. They will have a short break and then go to the educational breakout sessions. Those should be lots of fun. So there are 4 different options. You get to pick 2. I know it's hard sometimes when you want to do all of them, but all 4 are great options, and we'll highlight those for you later. And then, as mentioned, we'll finish with the lunch and learn option. So Amy, we're very delighted that you came to join us and to share your perspective on nursing. You played a big role at the University of Michigan for our rare disease patients, and we'd love to hear your thoughts.
Good morning, everyone, and thank you for asking me to be a part of this. I'm really excited, although I'm not great with technology, so bear with me. Here is my agenda. I'm going to be talking about the positive roles that nursing can have for chronic patients and their families. So we'll start with an introduction, then I'll go through a patient story that's near and dear to my heart. We'll talk about the unique needs of the families and their patients while managing chronic illness. I'll talk about nurse advocacy. We'll do a little summarization, and then we're open for questions and discussions. So a little bit about me. I am a Boston native. I am a very proud Children's Hospital of Boston former employee. I worked there to begin my pediatric career. I worked for 4 years, not on a hem-onc type of situation, but a surgical floor, but I loved it. It was incredible. I then moved to Michigan and have worked at Mott Children's Hospital, which is at the University of Michigan, since 1998. I floated to various units, which we'll talk about a little bit later. But I've been working solely as a pediatric hematology oncology nurse for 9 years now. I love it. I would never do anything else. I am so passionate about my families and my patients. I try to advocate as much as possible for their needs. I try to educate, help them make decisions, be a shoulder for them to cry on. I'm so blessed to have found my calling, and I strive every day to be the type of nurse that I would want as my own nurse or taking care of my children or a loved one. So patients and caregivers of those with chronic diseases, they have significant life changes upon diagnosis, and thereafter they live with a constant threat to their health. The patients do. Parents are always in fear of something happening to their child, caregivers to their loved ones. It's estimated that they spend 30 hours a week, caregivers and parents, and patients themselves, managing their care. They have to manage symptoms, medications, diets, complex treatment regimens, appointments. It's a full-time job on top of their other full-time job as parent, maybe working outside the home, things like that. The goal of nursing support should be making everyday life with a chronic illness as easy and as normal as possible. So I'm going to focus on how nurses can empower patients and families to self-manage their chronic diseases. I'm going to start with this patient story. A little bit about what I did at Mott before I became a solely peds hemonc nurse. I was a float nurse for 16 years, and I only floated to 4 units: hematology, oncology, cardiology. There was a gastro, pulmonary, and transplant unit, and an ortho neuro renal unit. I fell in love with the hemonc population, although I loved all the units that I worked on. When I was finally ready to give up floating and have a home base, hemonc was obviously the right choice for me. This is not a hemonc story, though. This is about taking care of a child on a neuro floor. Many years ago, I was on a neuro floor. I was taking care of a 2-year-old child who had neurosurgery the day before to place a shunt to correct hydrocephalus, which is increased fluid around your brain. This was on the day before. The day nurse reported to me that he had been stable. He was on a half a liter of oxygen, that he was awake and alert in the morning, but had been sleeping comfortably for most of the afternoon. After report, I went to check on him, and I found mom in distress. She was crying and a wreck, and just was so concerned because she said her child was really not just sleeping, that he was hard to wake up, and she was concerned because his oxygen saturations were dropping and that he was, not breathing comfortably. So she said that the day shift, when she brought up these concerns to her, the day shift nurse, and I'm not dissing all the nurses, I'm just saying that it's important to advocate even within your own, within your colleagues. She stated that the day shift kind of blew it off as just the anesthesia wearing off from the day before. But the mom didn't really believe this, and she felt really dismissed. So when I came in, I definitely found him to be difficult to arouse, and now his SATs had dropped into the 80s. So I had to increase his oxygen to 3/4 of a liter. Mom had told me a little bit more about her son, saying that, he was active, awake, he was a normal toddler before this, and that, he was doing great this morning, but he fell asleep around 1 and was harder and harder to wake as the hours passed. So I paged the resident to just update on the change in the patient's mental status and the increased oxygen requirement. And I also mentioned how concerned mom was. The resident told me that they'd come by to check on him in a bit. So as the evening went on, the little boy's status worsened. I paged the resident again. He said he'd be there shortly, but after another 30 minutes, the patient was requiring more oxygen. Mom was becoming more and more distraught. I just felt I needed to take charge. So I called the fellow, and he came to see the patient immediately. He assessed the toddler, he spoke to mom, and then called his attending. And within an hour, the patient was sent to the OR, where he was found to have some bleeding in his brain from the surgery the day prior. I hadn't worked on that unit for several days since this had happened, but I did hear through the little nurse grapevine that the patient was doing well, recovering, and would be discharged to home soon. The best thing for me, about a week later, I was a young nurse at this point. I passed the attending surgeon for the patient from that evening. He came up to me, stopped me. I didn't know he even knew who I was, and just told me he wanted me to know that because I advocated strongly for this patient, that and his mother, I was key in saving this little boy's life. It was one of the most proud, most memorable moments in my nursing career. However, the hero of the story is the mom. She knew her son best. She insisted something was seriously wrong. And I just want to show the importance that nurses should always listen to their patients' parents or caregivers. They are the experts on the patient, and we are novices by comparison. So I'd now like to talk about the unique needs of patients and families managing chronic illness. So the World Health Organization defines chronic illnesses As diseases of long duration and generally slow progression, these diseases can usually be controlled but not cured and include persistent and reported health problems, gradual changes over time, and an asynchronous evolution. It's a lot of gobbledygook, but chronic illnesses have disease-specific symptoms. Also, patients have invisible symptoms: pain, nausea, fatigue, mood changes. A patient's physical appearance may change, causing self-image issues. Depression may set in as all these changes come about. For the smaller, younger age children, the caregivers, the parents, are very vulnerable to depression and just anxiety and just completely being stressed out all the time. Chronic illness can also influence a patient or their parent caregiver's ability to work, their ability to attend school, participate in recreational and social activities. They kind of become isolated from their friends. Their whole life is basically turned upside down. The management of a chronic medical condition is complex. It requires coordinated action between healthcare providers and patients. This process, however, is not always easy, and it's complicated because many of the patients don't just have one chronic illness, they have many, especially in the immunohematology world. Sorry, that is a repeat of what I just said at the top. Parents and patients find it difficult frequently to manage appointments, coordinate appointments, manage the different treatment plans, understand the different treatment plans, and communicate effectively with their different healthcare providers from multidisciplinary teams. Chronic illness and its limitations are endured constantly, often for the remainder of a person's life. And people can't just simply take a vacation from what is happening with their body or their child's body or their loved ones' bodies. So moving on to nurses as advocates, we are well positioned to educate patients and families. We spend the most time with these patients and families, parents, as we are there with them, 8 to 12 hours a day at some points. I do practice primary care nursing in my department, and that means that I sign up for a patient to be their first nurse if I'm on staff that day. And then other nurses sign up to be the associate and the consistent caregivers. And this method helps just provide consistency and allows for us to really build that trusting relationship with our families and patients so that we can advocate best for them, support their decisions, and act in the best interest of their patients and families. Education is a huge part of what we do as nurses. We are constantly educating. It doesn't even seem sometimes like I am educating. Just by hand washing, I'm showing my patients and families how important it is to keep clean, keep a sanitary home, keep your patient loved one away from germs and other things. So little things like that. Patients and families are asking questions throughout my day. Answering simple questions is educating them. It's never ending, and it's a part of my job that I absolutely love. We use our voices, we use our experience to advocate for patients within their healthcare team. We educate and provide resources to help them self-manage their care. And we also are very good at, with a lot of team members also being good as well, and advising parents not to go Google crazy, fall down the rabbit hole, and just give them options for reliable sources on the web to find out information on their illness and to take everything with a grain of salt. Every patient is unique. Every patient's journey is unique. Nurses, we also advocate for families. I work in a hospital that is patient and family centered, and I would not want to work any other type of model for my nursing duties. I want to advocate for families, recognize their loved one's health. It affects everyone in the family. It is very intertwined with the family dynamic, and encouraging normalcy, normal home routines can have a huge positive effect on the entire family. It's easy to just focus on the patient, but it's important to incorporate all of the family who are all struggling with the diagnosis and the prognosis, their daily lives. It's important that we encourage families to, bring family around, educate family, things like that. It's important we actively listen to patients and families. We should support a patient, build a trusting relationship with them as best that we can, so that we can understand their unique needs, concerns, and expectations. Nurses, we need to advise caregivers, parents, usually in my job, that it is so important to take care of yourself in order to take care of your loved one. And sometimes we have to force these parents to take 5 minutes to do something other than be in the room with their child. So we encourage them to take a shower, try to get a little bit of sleep, eat properly, carve out 5 minutes to go sit by a window with a nice cup of coffee. Just breathe and refocus for the day. Nurse, we also advise patients to be realistic about what they can do for everyone. Your life kind of stops on the day that you're diagnosed or your family member is diagnosed, but it can restart again. It's just going to be different. It's going to be a little unrecognizable, but it's going to all end up working out in the end. You will find a way that hopefully works out for everyone. And I will encourage you to find help for your family and for yourself, to help siblings get to games, help homework to get done, help dad go to work for a little while. These are general things, and you need to let go of things that you thought were maybe important before, such as, school parties, or just, an impeccably clean house. That may not happen right now. Clean is good, tidy is good, clean is good, but don't be obsessed. You don't have time. Chronic illness, your treatment shifts, things constantly shift. You have to learn to be flexible the best you can. It's so important for them to build a support system. If they don't have family, then the community has lots of resources. Friends, church, neighbors, sports teams are always wanting to rally around people. There are support groups. I try to connect patients with the resources that I have, or get them in touch with social workers and things like that to get the resources that they could need. The internet is also, it's a love-hate thing for me, but there are great, I'm old school, so Facebook pages, probably Instagram really now, but Facebook pages and blogs that are made by parents, patients, families that have gone through the same thing or are going through the same thing. Connecting on these pages or blogs can really serve as a strong support for family members and patients, because it can let them know that they're not alone and there are people out there that are there for you. I have to teach them to be firm sometimes with their friends and families who want to visit. Not everybody understands that, a little cough or cold can really impact the health of a patient. So I just kind of hone in to the patient and family that anyone sick should not be allowed to visit the patient at any time, even at home, while they are, in immunocompromised state, which is frequently a lot of the time. Everybody needs to wash their hands all the time. Masks need to be worn around the patient if they are severely immunocompromised. And unfortunately, patients really can't go out in public when they're super immunocompromised without taking a lot of precautions. Sorry, I skipped to the other screen, but the most important thing is that I need to empower these families and patients to speak up for themselves and let them know they're never going to regret standing up for their loved one or their child. So in summary, one of the best ways that a nurse can advocate for parents, patients, and caregivers is to meet them where they are and where they're coming from. It's important to know their social background, socioeconomic factors, just as much as you can know about a patient before their lives drastically changed and they came into your life. The goal of my nursing and nursing support should be to make everyday life with a chronic illness easier for patients and families so that they can lead as normal a life as possible. Thank you. And I think I'm ready to talk or discuss or answer questions.
Hi, Amy. Thank you so much for that wonderful presentation. I'm a huge fan of Amy. I've known Amy for, how old is Elia now? 6. So over 6 years. Amy and I weren't very close when we first met in the infusion clinic. We had a primary who was assigned to us, Laura. And if she wasn't there, Amy picked us up. And then I slowly learned who Laura was, or who Amy was. And at first, she was always the fun one. She's bringing light to the entire floor, to the entire unit. She's in costume more than she's in regular clothes. She takes time to decorate the unit, to make everything sparkle. That's the best way that I can describe it, is she brings that added sparkle. And most importantly, as she said, how she takes time to communicate to patients, to really take time for themselves, and to feel like they have the strength to advocate for themselves. She advocates so much for them to give them the strength to advocate for themselves. And it's a very big thing. And I commend you for that, Amy. And thank you for everything and all the support you've given that entire unit for so many years. We are so grateful to have you.
Thank you so much. I love what I do.
And it shows. I do want to open the floor for any questions. You may utilize the chat, or we can focus here. You can unmute yourselves if you'd like, and we can kind of have a discussion for anyone who has any questions for Amy. Oh, sorry, Corey?
Sorry. Hi. Yes. Hi, Amy. My name is Corey Berman, and I'm a social worker at Nationwide Children's Hospital. Thank you for your presentation. It sounds like your scope of practice is very wide. You take a very holistic approach with your families, and I appreciate that as a social worker. I was just wondering if you, your team has, I know you reference social work. I didn't know if
I'm sorry, Corey,
you
you kind of broke up at that when you actually asked the question.
have other psychosocial how could speak me to work with us.
I'm sorry. I didn't hear the question. I apologize so
Sorry,
much.
Corey, were you asking if she works with a social worker in her department?
I think she was asking what other psychosocial services are available to patients and how they sort of integrate and work together.
Oh, very good.
Okay, I'm
So to answer your question, Corey, we have a multidisciplinary team in place. However, in hospitals, it's tough in hospitals right now. We're understaffed. We have social workers on staff, but we need about 15 more, in my opinion. We have a wonderful education coordinator named Beth Stuchel, who is the liaison for these patients and families for their schools, colleges, daycare. She handles everything. She's incredible. She's always on the ready to help. And then we newly have a psychologist on staff, which is wonderful. Her name is Sunny, which I think is just fabulous. And she's so great meeting with the patients, in my infusion area. She has formal appointments with them as needed. So we have a great setup. We just, of course, can always use more. Oh, we have Child Life too. I don't want to forget them. They're so important in a patient's stay. They make things easier, better. They provide support that I don't even realize the patients need. They're so wonderful and underappreciated.
I agree to that. Child Life is amazing. And I love that at University of Michigan, CS Children's Hospital, when you even come for a lab draw, a clinic visit, just any type of level of an appointment, the first question is, do you need Child Life support for this appointment? And then you just wait a couple moments and someone will be provided for you with some fun, some bubbles, some things to distract, an iPad loaded up with games. And not just that, when one particular moment that I remember, it was when my son received a port and they brought out this child life-sized doll. I don't know. His name was Doug. I believe his name was Doug. And Doug had a port. And we learned how to access Doug. And we went through the motions with Doug. And my son wanted to take him home, loved him so much, and really helped ease the process. So they do a lot of teaching tools, a lot of guidance. So child life is important. Thank you for speaking up on that. I don't know if we have anyone from child life here. But I do want to, are there any other questions for Amy? Amy, I would love to keep you on so while we move into the next segment. I do want to identify some more partners that are part of our care team. And we're talking of social work, we're talking nursing, we are talking, we just spoke about child life. There are other levels that sometimes patients are a little confused who we're interacting with and who do we address all the concerns to, and what role do they play, and how much can they do for us, and are they the right person to approach? I just saw someone log on here. Her name is Laura, and Laura is she was a med student, now a fellow, and I was wondering if you could give us some guidance into those roles. We also have on the call right now Anna Matthews, who I know is a current med student at Vanderbilt. And I would love for both of you, if you don't mind, talking a little bit about your current roles, because we do see you at some of our appointments and we do move through the day with you. And what role do you play for patient care, and what can they ask of you, and what falls under your scope? So I'm going to give the floor to both of you. Please, if you don't mind, introducing yourselves, introducing your role, let us know your duties, and we're going to see if there's any similarities or differences between the universities, because we have one from the University of Michigan and one from Vanderbilt.
Awesome. Thank you, Evelyn. My name is Laura Boomeroon, and I am one of the third-year pediatric HEMONC fellows at Mott. So thank you for having me. I'll talk a little bit about kind of the process in like the medical training that might shed some light on the differences in roles and of stages. And then I think Anna can kind of comment too from her experience at her institution, and then also as a different level kind of in training. But, you as families see a variety of different individuals in clinic, and it can get overwhelming on whose role is what does this person do? How does this impact my child's care or my own care? So as a medical student, you're rotating through different kind of rotations for kind of a temporary amount of time, or if you have a specific interest in something, then you might kind of go back to that area. And it could be in pediatric immunology, immunohematology, and kind of working in conjunction with the rest of the medical team, which may be composed of the medical resident, the medical fellow, a nurse practitioner, and then the supervising physician. So I'll kind of delve into the roles of like residents and fellows. I think that in a subspecialty like immunohem and peds hemonc, the core kind of care team, a lot of the time, at least in our institution, will consist of a nurse practitioner, a attending physician, and then a lot of the time a fellow will be involved as a primary care provider too for patients. And our role's different than the resident role, because I think we are more involved in patient care in this kind of unique population of patients. And so if there's any question, please feel free to ask any person on the care team, but kind of focusing more on the subspecialty or the specific disease would be kind of a fellow or an attending or a nurse practitioner in that subspecialty. Yeah, kind of a gist, and I can clarify anything if there's any questions that anyone has, or kind of turn it over to Anna.
Hi, Anna. Let's go into, if you don't mind describing your role and some of your duties Vanderbilt, if you wouldn't mind.
Hi, so I'm Anna Matthews. I'm a fourth-year medical student at Vanderbilt. Just submitted my residency applications yesterday, actually.
Oh, congratulations.
I haven't spent that much time in peds, hemonc, in clinical settings since I'm a medical student. And as Laura mentioned, you rotate through a bunch of different specialties as part of medical student process. However, in pretty much all specialties throughout medical school, what you end up doing is you progress from more of a shadowing opportunity situation in the first and second year into more of a residency light role in third and fourth year. What I have consistently heard is the medical students' most valuable asset is that we have a little bit more time to spend with our patients because we usually have a smaller census that we're working with. On like my internal medicine and pediatrics rotations, when I carried patients in my second and third years, I would carry like only 1 to 3 or so, sometimes up to 5, but that was always a much smaller census than the residents or attendings. And so I got to go spend a large amount of time with these patients when I was admitting them, or when I was talking with them in the morning. I had time to go back and chat with them for an hour in the afternoon about how they were feeling and make sure that they had all the things they needed. And so the way that I have often heard a medical student's role is actually pretty similar to some of the nursing's roles. We have the time to sit there and talk to them for long periods of time. I found out about like why a patient had been insisting on wanting to go home, even though he had like a diabetic foot ulcer and was going to need surgery. He kept insisting that he didn't want the surgery and wanted to go home, and it's because his husband had stage 4 cancer and was on hospice and had weeks to live. But no one else had gotten the chance to talk to him for a longer period of time in order to find that information out. And so I think that's really where medical students get the chance to shine, is that we have more time to talk with patients about their social determinants of health, about their home situations, and we can often collect a more detailed history and physical, and collect information that may end up being useful down the line that no one thought might come up. We also have a chance to sit and explain things or answer questions. I've done a lot of running in between teams, trying to find PTOT, trying to find child life, trying to find the nurse, and getting information places faster than we might not otherwise be able to get it. Also being able to communicate between different teams, going to find the peds hemonc team when I was on palliative, and I would go and listen in on their rounds for my patient and then go back to the palliative team and report. And so there was less of a, we played tag slightly less than we otherwise would have, because I was able to actually listen in on rounds since I had that extra time.
I have a question. I know both of you mentioned having those extra times with patients. Is there anything during your education that gives you coaching skills with patient skills, having that time and the ways of communicating and kind of things that you absorb, things you note down? I know as a patient, when we're extremely stressed, we ramble and we get really nervous. We don't know what to do. We don't know what to say. We don't know who we're saying too much to. And I just want to know a little bit more about the education that goes towards interacting with patients.
Yeah, I think that every student's experience is different, depending on kind of like the curriculum of their school. But I know that in my training, we had formal simulated experiences with patients, which kind of helped step into that realm. You know, you are reading textbooks, listening to lectures, taking exams, and then all of a sudden you're catapulted into real life with real people. And that's a huge change. And I think that there's a skill set that needs to be learned and recognized before we get catapulted into that world. And so I had some formal training in medical school about, interacting with families, interacting with patients. But I can tell you from just my experience so far in my career, really learning interacting with patients and that patient care aspect and like bedside manner really comes with just time and working with families and understanding and kind of putting yourself where they're at. Oftentimes I will try to kind of put myself in a family's shoes and imagine that this was going on in my family and trying to be sensitive and empathetic towards that, because it's hard. And sometimes I think we talk too fast, or we say things that maybe don't make sense, or we say kind of medical jargon that we don't recognize that we're saying. So taking a step back and really being mindful of the words that we're using, and kind of what we're talking about, and making sure that we're leaving space and holding space for anyone to answer or to ask any question at all.
I would agree with all of that. Vanderbilt puts a lot of emphasis on getting us into patient care early. So in our first year, we do also have didactics about interacting with patients and patient families. We also have simulated patient experiences first year, but we also have a longitudinal clinic experience during our first year, where we spend maybe 5 hours a week from pretty much our first week of medical school through the end of the year, going to the same clinic, so that we can start early on working with patients and working with patient families and getting that experience. Because like Laura said, interacting with patients, patient families is really the best way to learn this. We also have only 1 year of formal didactics or book learning, and then we go straight into clerkships, which is where we start interacting with patients in our second year. So we get into patient care early, both in our didactics portion and in our patient care section of the curriculum.
Is there any tools that you've learned through your educational process that you wish, I don't know if it's like a bullet point of things to ask and how to go, that you wish that patients had in front of them, kind of like a coaching tool? I always feel like patients need to be prepared for these appointments. One, understanding who they're interacting with and at what level. And two, again, this is why I thought this session was important, just understand what session that can provide. Amy, I see you're back. I also wanted to ask the same question from the nursing point of view as well, of what tools were you given, communication techniques for patients, of ways to be coached when you're interacting with patients? I know that you kind of learn, like you said, being in front and getting that one-on-one time and learning. But I just want to know if there's any similarities, because I know they're different programs.
And I'll interject. I always encourage parents to write everything down all day, all night. Paper towel, anything. I usually try to get them paper if they don't have it, in a pen. Write down your questions, because you're not going to remember them when you have a doctor in front of you. So that is a big piece of advice that I kind of just stick it right to them. Do it, do it, do it.
I second that, Amy. I always tell families, when I'm sitting in a room and kind of opening the floor to them to ask any questions, a lot of the time that's met with, oh, I don't know. And it's very overwhelming. I can imagine to be in there. I have been on the other side of things and felt the same way in a visit where, once you leave the visit, once you get in the car and you're driving home, all of these questions and all of these thoughts kind of like come to the surface, and you're wondering why I didn't ask that, or, oh, I should have brought this up. Always writing things down before and after, and just, even afterwards, if you've had a visit and all of these questions come up, just send a message to your care team, and people and providers are more than happy to answer. We know that these things happen. They happen to us. And so just kind of feeling like you have, and knowing that it's, the communication, we want open communication, and we want to make sure all questions are answered.
And I really appreciate you saying that, because sometimes patients feel that their questions are too silly to be asked, and then they forget because they don't feel powerful enough to like just ask that, to feel like they want to feel like they understood and they absorbed it, because they want to, especially caretakers, because we want to feel like we understood and we can do our job, and we don't want to feel like less that we can't do our job. So it's when you're in stressful situations like that, it's a power play within yourselves. So like, you want to write it all down. You want to remember it. You want to leave yourself a little note in your phone or a voice record, just saying, this is what happened this day. I always say, just as soon as something happens, get a journal and just start journaling. Like every interaction. Of course, you can get fuller and go down even to meals and things you did today, but even start noticing things that you did for yourself. Like Amy said, it's important to jot down everything from the smallest to the biggest significance, and the smallest of questions to the biggest of questions. We do have Phil who's on the call right now, and Phil is a social worker. And I would really appreciate your point of view, Phil, of interacting with patients, letting us know your role and what you provide to patients, and what's within your scope, and what patients can ask of their social workers in their setting.
No, hi, Evelyn. Thanks for introducing me. Yeah, happy to talk a little bit about my role. And my colleague Vanessa's trying to jump on as well. So she may be joining us. Oh, she is joining us. So she can speak to it as well. But so I am, just to give you a little more background, I am a pediatric blood marrow transplant social worker with the University of Minnesota Masonic Children's Hospital. And so I don't work exclusively with patients and families with immunodeficiencies, but we have a fair few number of families that have come through the transplant process and or follow, with our transplant team if they're kind of like looking at transplant sometime in the future. And so sometimes they follow for years pre-transplant. And so I've done this for about 5 years, and then before that, I worked in an adult hospital for about 5 years. So I'm pretty familiar with medical social work generally, we kind of tend in a medical setting tend to wear a lot of different hats. In this current setting, we see patients outpatient and inpatient. We're kind of embedded with the treatment team, so we work with the patients and families. In addition to that, the physicians and the nurse coordinators and the nurses and the inpatient team and everybody. And so would say we kind of framed up to our patients and families. Our role is to really help them get through the transplant process. And we do that by supporting them both logistically and emotionally. So there's 3 clinical social workers in our transplant program, and we're all clinical social workers, and so provide kind of supportive counseling and therapy to families as they're going through this process, trying to help them cope. We try to help explain things. Some families need things explained a little bit more in layman's terms. So we try to help explain things a little bit more, that's with things that are in our scope to explain, and then also assessing if families are understanding everything or maybe needing more information from the clinical team and the providers. We sometimes act as kind of a mediating force if there's families are expressing questions or concerns that they feel like the clinical team isn't addressing, or if the clinical team is feeling like the family's not getting something. We can kind of help bridge that gap. We help families and patients with resources in terms of like if they need help traveling to our state and city to undergo treatment, if they're from a different part of the country, lodging, work, school for the patient, with various grants to help them defray loss of income, medical travel costs, things like that. We answer a lot of questions on the front end for families about, what are the program requirements for undergoing a bone marrow transplant, because there's several requirements as far as, having to remain close to the transplant hospital for a certain period of time, having a certain, we require a caregiver, and so making sure the family's aware that they post-transplant, when they're out of the hospital, they'll need a caregiver with them 24/7, even if they're an adult. That's just a BMT requirement. So we help families kind of go through some of those like program requirements and then how to make that work. And we're kind of just here to like really support the family through the whole process. And certainly to your, when I jumped on, you were talking about patients and families, having questions that come up after the fact, and we certainly see that a lot in the transplant world, because we're giving so much information on the front end that it would be impossible to absorb all that information and to think of all the questions right in that moment. And so we certainly do encourage families to reach back out to us days after their consult or after their transplant workup with questions. We always provide them with, like, I think it's important, at least in our role, to provide them with our contact information right from the front end, because we know they'll be following up with questions for us. So, that's just kind of, I think, like a brief overview of our role and how it maybe pertains to the topics you guys are discussing.
Your role is way bigger than I thought.
Oh.
So, when social worker is approached in the setting, normally like, there's no additional resources I need at this time, but not thinking that you can help mediate with the clinicians, that I could
sure.
maybe just speak to you and address some concerns, and you
Mhm.
can help those. Again, you're advocating for us as well in that moment. And
Yep.
I did not realize that was one of the roles. You always think like
Mhm.
social work, like, oh, outside resources, travel.
Mhm.
I think I'm good. We have a good family unit.
Yep.
Like I got a good support system.
Yep.
No real need. I think social work should always be integrated because again, your scope is so broad
Right.
and we forget. So
Mhm.
if you're ever approached, and just make sure, and even if a family seems like, no, I really don't need to speak, encourage them to
Mhm.
really say how important it is and their broad role.
Absolutely.
I don't know, Vanessa, if you have any more to say. Again, I know I was one of them to say, oh, I don't need social work to come today. I'm good. We're good. Everything's fine. We have everything under control. But how amazing, because a year down the road, not realizing you'd be in the situation later, I would have left someone's number at some point and I didn't have that contact. So you don't realize when you'll need them. So Vanessa,
Yeah.
hello, nice,
Hello.
nice to meet you.
Thank you all for having us and good morning. Phil did a great job of explaining our role. I think that as you said, it can be a large scope of practice, and so sometimes not always easy to kind of find point or explain to families exactly our role. But I think a big component that's often missed, because I do think traditionally people do hear social work and they assume community resources and support. And while that is such a critical point of our role, we also are licensed independent clinical social workers, which means in theory in the community we could be practicing as private therapists. So we do have a large mental health background as well. So we bring that to our work for families, because I think often when you are going through transplant, you just have to put one foot in front of the other. And even for families that feel like we're coping well, we have such a large support network, we don't have questions, there are often times as we're able to build rapport and get to know families that if you have a moment or an opportunity to really think through, whoa, this is quite an impact, this experience, how it will impact our future, we can really start to work through some of those larger themes so that when getting back to home, it doesn't kind of hit all at once. So I just want to highlight that as well, that I think it's nice that we are able to meet family where their needs are at. Sometimes it is much more on an emotional standpoint. Other times it is, they're traveling from out of state and can't even conceptualize the idea of short-term relocation. What does that mean for their family? So it's just a very nice opportunity for us to have an individualized approach and meet each family and kind of just where they're at and rely on them to help guide the work that we do.
Amazing. Very important. And I appreciate that. And I know that, Phil, you mentioned transplant, and another key person that I feel like plays a role that maybe isn't in front of patients as much would be the pharmacist. And I know that we have a pharmacist on here. And I wanted, Nathan, if you wouldn't mind speaking a little bit more as well of the role that the pharmacist plays with the patient. We'd love to hear from you if you're available. Nathan, like,
Hey, can you guys hear me?
we can. Hi, how are
Awesome.
you?
Hi, good morning. I'm good. How are you guys today?
Good, thank you. I
Good.
keep pulling people out of the crowd, but we have a pretty big panel growing here, and I'm very excited for questions in a little bit. But I would love for you to tell us your role and the scope of your work, and how much you interact with patients, if you wouldn't mind.
Yeah, of course. My name's Nathan. I'm a pharmacist here at University of Michigan. I'm just recently starting in a clinic with Dr. Walkovich here, but I have experience working in some symptom management clinics in the head and neck cancer area as well over in our cancer center. But pharmacists really have a lot of different roles, especially working with patients. You'll see us on the outpatient end of things in our clinics. You'll see us in infusion. You'll see us on the inpatient teams as well as in research teams. So there are a lot of different things that we'll do. For education wise, we'll help reinforce medication concepts like administration of medications to patients, whether or not, especially for pediatric patients, if they need to dilute medications, and dosing and side effects on how they're going to monitor those medications. We also going to help with gaining additional insight on anything that the patient any sort of medication needs they may have. If they're expressing any sort of symptoms that need additional medication management, we help with the primary team, as well as coordinate with nursing and on helping address those for the patient. We also look and address any sort of medication access issues that the patient may have. And so we have a medication access team, at least here at University of Michigan, that we help coordinate with. So we reached out to them and helped coordinate whether patients are getting medications from their insurance companies, or they're coming from the institution, et cetera, et cetera. So really, we just try to be a point person, a resource for both our providers and our nurses, as well as our patients, and try to reinforce some concepts with them. And also just help review any sort of treatment plans and any sort of dosing infusion questions that these nurses or providers have, as well as just review any sort of like interactions, compatibility issues, etc. So we really we work behind the scenes a lot of times, but when it comes to interacting with patients, we really just try to reinforce education that they have, and we really try to touch base with any sort of issues that they may have with gaining access to their medications, what to expect with medications, and looking at what different side effects they may have, and what to be looking out for as well. So we really just try to be an additional resource for them, because some of these patients are starting a lot of different medications and they don't know how they should be taking them, and just having them build that understanding of some of these key concepts, I think is great for seeing where we are on the medical team, but also just being a touch person for everyone else within our team as well, a primary team.
Wonderful. Awesome. I want to know from your point of view, and I'm going to ask everyone this. I have a question for everyone. What do you think, we'll start with you, Nathan. What do you think is the biggest hurdle for patients? For each of from what you interact with them, I just wanted to, from your point of view, on your side of things, we may not think this, but what do you think is the biggest hurdle for patients going through either a rare disease diagnosis or being in a specialty clinic setting?
So again, just reinforce, I'm fairly new to this clinic position here, so my experience is somewhat limited with my brief interactions with some patients here. But for me, I think the biggest issues have been having patients understand like where their medications are coming from specifically, the whole med access issue and billing issue can be complicated for patients, so explaining some of that to them, and then also just explaining when they're starting a bunch of different medications, explaining the various different dosing, the role of it, just
what not to
reinforcing
mix
those
with
concepts.
what.
Yeah,
Don't
exactly.
don't take your
Yeah,
iron with
yeah.
this,
So
and
just
separate these things a
reinforcing
couple
those
hours out.
primarily. Yeah.
Do you give patients a print off of that? I always try to remember, but I don't know that I ever, is that a part of like patient education? Is there prints off of what medications not to take with what, or is it just like on their pharmacist handout, or do you guys, I remember one time getting like a handwritten note. So I didn't know if there was anything more formal.
Yeah, so I mean, we may have some education for patients. Obviously, it's not completely comprehensive. So, it just depends on what the medication is and how it's going to interact. There are certain enzymes that, are substrates of and interact with a bunch of different medications. And so it would be impossible to include all of those. But some, key important ones that a patient may interact with, like different, juices, like grapefruit is a very common one. Other common medications that they may be having, some over-the-counter medications that they may be interacting with. I think those are obviously very important. And then also just reinforcing with patients that they're going to be starting anything new, any sort of vitamins, herbals, any sort of new over-the-counter medication that we're not aware of, just to make us aware of it so we can be
all
reviewing
be
those
communicated.
interactions specifically. I think those are all very important concepts to reinforce with patients, because that's not always something that they would, think about.
Right.
Taking a new vitamin or an herbal product, it's not something that you would think would interact with a medication per se, or a grapefruit juice, So
Yes,
I think those are all very,
juice.
I think those are all very important to just connect the dots patient, and let them know that we're here as a resource for them, and to be helpful for any sort of questions they may have.
And Nathan, I'm sure you interact with Amy. Have you interacted with Amy before in the infusion?
Yes, I have many
Hi,
times.
Nathan.
Hi, Amy.
I actually have I think my opinion on hurdles for the patients and families is communicating. I think communicating with the team members. There's so many different people, pharmacy, social work, doctors, all variations of doctors. They have to understand the hierarchy of attending, fellow third year, second
Trainee,
year. It's
med
just
student.
kind
Yeah,
of a nightmare. I get
6
confused still
years.
sometimes. I think like they don't always know who their team are. They don't know what everybody they're supposed to contact. I try to help them with contact information for people. I also feel like there's a lack of transparency sometimes from team members to parents, and that's a huge hurdle and a problem that we all need to be better about. And Nathan at pharmacy is amazing. They're such an essential resource for us, for safety, for questions. They're always open to anything basically we need, and social work as well. I feel like social work even helps the staff. So they support us. So I always wonder who supports the social worker, but anyways.
I do have to say, even from when I started out, I thought PGY3 or PGY6 was like a name of a disorder, not knowing it was postgraduate year 3, postgraduate year 6. No idea. I thought it was like a different type of program. So I appreciate you mentioning that, Amy, because it's a little confusing, and which is why we're here today. And I think it's really effective for everyone to explain their role. And it's a resource that it should be posted, and patients should have access to understand who they can speak to, what roles each individual does, and what scope of patient care falls under their responsibilities. And you hope everything is transparent, because that's what helps build that partnership with your provider, your partnership with your care team. Having the trust to go both ways. I trust that when you're at home, you'll report everything to me so that I can give you the best care possible. And I trust that when I'm here in the setting, you're advocating for me on all ends of the spectrum to make sure that I have the best care possible. So kind of goes both ways. Laura, I see you're on. I want to know what your biggest hurdles that maybe you've seen. You've been around for a little bit, few years now. I can't remember what.
UI.
If you could let us know, I know you've had a lot of interaction with patients, so what you think their hurdles may be.
Yeah, I think that in specifically in like a rare diagnosis clinic and realm, the biggest hurdle is uncertainty. Uncertainty of the system, uncertainty of what the diagnosis is for yourself or for a loved one, and knowing that sometimes it can take time to get to that diagnosis, which the anxiety and the anticipation leading up to that diagnosis is very overwhelming. And so I think that, and just I second Amy in having open communication with your care team. And you mentioned earlier about a silly question. I always tell families there is no such thing as a silly question. Ask anything, and sometimes what you think is a silly question leads to a much larger discussion and provides a lot more information to the care team that can be really, really helpful. So just the uncertainty of everything that's happening, and to kind of mitigate that, I think, like I said, having open communication and knowing that, we're working and it can take some time in rare diagnoses to get to the answer, but that people are thinking hard about your case or your loved one's case.
Yeah, I appreciate you saying that. That it can take some time. Things take lots of time in some cases, months in some cases. And, sometimes patients can feel frazzled that what they forgot about me, or am I being overlooked, or, and that's why behind the scenes, it's important to know that everything's going good. Who would be that person in between appointments if, say, something was happening? Is there any letters that go out just saying, like, things are still in process? Is there, or is it just like a follow-up between the care team? I don't know if we have any like clinic coordinators here on this call today, but I know that they do a fantastic job of advocating and communicating for patients. I'm not sure if we have one on the call today. But Laura, you've interacted with a clinic care coordinator. Can you tell us a little bit more about their responsibilities? I know it's not within your scope, but what have you noticed?
Yeah, and I think every hospital system kind of runs a little bit differently. But in, our specific system, and I think in a lot of rare disorders clinics, the benefit of having a care coordinator, they can kind of be the mediator in between the treatment team and a family, and have either being present at visits or making sure that follow-up is set up with different labs, images, or anything that needs to be scheduled for diagnosis or workup and or treatment of whatever kind of process is happening. So I think that they're a huge asset, and really beneficial in kind of coordinating things and relaying things back in between families and providers, and kind of helping bridge the gap in communication. And I think that, just being an advocate for yourself, being an advocate for your loved one. If you're worried or concerned, just call or ask or send a message, and someone from the care team, whether it's the care coordinator, whether it's a clinic nurse, whether it's the nurse practitioner, the fellow, the attending, just sending a portal message or an email, or even giving a call and just touching base, and saying, are there any updates I haven't heard, or I'm just really worried, I think is something that I always want to tell families, and then tell loved ones of my own, saying, be your own advocate and be an advocate for your loved one.
Wonderful. Advocating is so important. And is there, in each of your positions, I know that you said there's like a lot of different subspecialties that you work in while you're learning and educating within. I know Anna spoke on that earlier. Different departments that you're working in. Do you see a lot of, how do I put it? Do you see that other departments are very open or receptive to rare disease patients? Or do you feel like that kind of like involves the immunoheme, the BMT, like it's in a certain realm of its own? Or do you think other subspecialties are fully aware, it's at the forefront of their minds? Because sometimes you feel as a rare disease patient, like if you don't have a diagnosis in some amount of time and you've been going to, like, you don't know where you fall.
Yeah, I think that can be challenging for families, because you're kind of dipping into multiple subspecialties, and everyone kind of has their lane that they know about and what their expertise is in. And a lot of rare diseases kind of tap into many different lanes. So it can kind of feel like you don't have a medical home, that you're kind of like wrangling between many different providers. And I think that's where kind of a care coordinator can really help in kind of pulling everyone together. And, depending on where you feel that your medical home is, kind of really leaning on that clinical care team to help answer questions. And if they can't answer a question because it's in kind of a different subspecialty, kind of either providing you resources or reaching out to those other subspecialties and finding ways to get questions answered, and making sure that you feel confident in what's going on and understanding what's going on.
which when you say that, like trying to find your medical home, and then you realize how many subspecialties are within NICER.
Yeah, yeah, exactly. Yeah.
It's just such an amazing thing from the outside in to realize that, immunology, hematology, rheumatology, like everyone is here. Everyone sees facets of different rare disease and see where they all stem from. Could I ask, I know that we're talking for patients and advocating. I would like to know if we know some of the resources within the hospital setting, within the care setting. If Phil and Vanessa are still on, I do have a question for patients with rare disease. Again, we're talking about finding their medical home, finding where they belong. In that in between, what are publicly accessible resources for these types of patients that are with rare disorders that don't exactly, may not be labeled their disease yet, but still know that they are chronic, they have things that they're working through, they are medicated, and what is accessible to them at that level?
Yeah, I think there are various community resources and support. And I think for each of our patients and families, they all do a really great job of networking and meeting other families who are maybe experiencing similar challenges or barriers, but also just really drawing on each other to focus on their strengths and their ability to navigate the process. I think as we work with families just on a very large spectrum of diagnoses, there are several different little areas or groups that, based on the diagnosis, have had an established network or resource support, but it would just be kind of navigating what's out in the community.
And I can just kind of piggyback off that and say, and sometimes what we're doing is coaching families on, like, oh, you're from a state that has a specialty disability medical assistance program that you can access as a secondary insurance that'll help defray costs from your primary insurance, helping families explore, does their child qualify for like supplemental security income or SSI, like Social Security disability for kids, some of those sorts of things that can be helpful. And then, there's some, things that we, for families that are coming for either consultations or appointments of specialty care for rare diseases or coming for a transplant, the whole spectrum. We have a lot of families that utilize, some resources that most major cities have, like Ronald McDonald House for lodging and some of those sorts of things. I think that's one of the hardest parts for the families we see, and I think probably true for a lot of patients that are dealing with rare diseases, even if they're not going forward with transplant, is, for a particular rare disease, you might have to go see a doctor that's across the country from you. And with the way our like insurance and reimbursement systems are coordinated, you can't often do it telemedicine. So from California to come to Minnesota, you usually need to come here, and that's really hard for families just for like a consultation appointment with a specialist. And so it's a lot for families. So that's partially why we exist. But you're kind of asking what are some of like the barriers, and I think just the way our system's set up is makes it difficult for patients and families with rare diseases or who needs like really specialty treatment that only is offered maybe at a handful of places around the country.
Wow. I thank you for that. And it's a kind of like a hard, spot to be in, right? Until you officially have that title. And unfortunately it feels like a label to us at some point, and you carry that with you for majority of your life. I do have a question for Anna. If you're back on. Anna, I know that in the beginning of this, you said you just applied for your residency. I want to know, because we were talking about the education that you got, different subspecialties. I want to know, was there, and I want to ask each one of you, if there is a certain patient that inspired you that career decision or impacted your level of care moving forward? Has there been a specific instance during your education, your training, your current role that has inspired or changed the way you've again, you just applied for a residency. So what made you choose that? Was it a patient? Is there something that inspired that move?
Yeah. So I applied into emergency medicine. I have a couple of patients who definitely inspired my choices to go into the medicine side of medicine. One of whom was a patient who I saw in the hepatology service, which was not my first choice for my internal medicine rotation, but I get assigned to hepatology. A lot of my patients were very sick. Pretty much all of them ended up going on hospice. One patient in particular had basically the entire week, 2 weeks I was there. For the first week, we were expecting her to die pretty much every day. One day she started getting much sicker. And so one of the residents was going in the room and explaining all of like the illness and progression and trying to talk about hospice with the patient and her husband. And she kept requesting name brand chapstick, which we did not have on the floor. And so the resident came back in and was like, are either of you free right now? And can you go find name brand chapstick? Because we don't have any in this hospital. And she'd already went and checked the gift shop and couldn't find any. So I went and wandered around and I found some in the back corner of the gift shop, but there was also a Walgreens down the street that I was going to go to next. Ended up getting her a bunch of different name brand chapsticks. Ended up spending about an hour in that room. The resident went back up and talked with the husband, but the patient ended up talking to me about how basically she was incredibly bored. She was too confused to like follow TV or music or anything like that, but being in a hospital room without being able to look out the window or listen to anything or do much of anything is incredibly boring. And so we ended up talking for a while and came up with a solution of listening to basically spa music, which was non-complex enough that she could continue to listen to it without it being confusing or irritating. So we set that up for her using the hospital room system. And that actually is basically what pushed me into wanting to do more medicine aspects of medicine instead of like surgery aspects, was being able to actually have that big of an impact on a patient's life. We got her basically her dying wish of name brand chapstick. And similarly in the ED, being able to do other small things that make people's day better. Having more time in the ED, I've gotten to explain to patients about their metastatic cancer diagnosis, that based off of imaging, we think they probably have metastatic cancer, and getting to spend that time to explain it to them so that they're not blindsided when they get upstairs, or being able to get them water when they are allowed to drink water and are not NPO, but they've been like sitting in their hospital room for like 4 hours and are incredibly thirsty. And so I would say that that was probably the most meaningful patient interaction I've had in medical school. I'm not sure how much it contributed to me going into emergency medicine specifically, but it definitely impacted the way that I view patient care and impacted the way that I view my practice going forward.
Oh, that's wonderful. Thank you for sharing that story. And you gave me goosebumps when, oh boy, you gave me goosebumps. No, I was so glad that you were there for that patient, were able to provide that for patient. And you cared so much to go to the store and find that name brand chapstick and, find solutions for that patient just to put them at ease. And it's really amazing. It's so meaningful to that person. And I'm going to ask Phil, sorry, Laura, I'm going to ask Phil and Vanessa to go next, because then I'm going to have a follow-up question for you. But is there, whoever would like to go first, is there a patient story that you care to share with us that was meaningful during your careers so far?
I can start. I don't know that I have a specific patient. I think, I got into medical social work kind of straight through grad school, like internship, and sort of stayed in this role, in this field. I just think what I started seeing pretty immediately, and I've seen throughout my career in this area, is how much a major medical issue, whether it's a rare disease or not, can really just throw a patient and family's life into a complete tailspin. And how much support, even someone who was like good, well-resourced, functioning well, good job, good support system, really, this sort of the rare, a rare disease or a really debilitating, medical issue can really really turn things upside down, and the whole family and the patient needs support. And I think it really, drove me to want to kind of go deeper into this field and continue to support these patients and families, because it's just very apparent how much need there is out there in the medical world. So
Thank you
Yeah.
for sharing that, Vanessa. I'm gonna go to you, and then I'll ask you both a
Okay.
question.
And I will just apologize in advance. This is going to sound very cliche and flowery, and I truly mean it. I think when reflecting on a specific patient example, it would probably be nearly impossible, because I do feel like on a daily basis, whether it's big or small, I can point to an example of resiliency and strength that is just, similar to Anna's story, can give you those goosebumps and that special feeling of we're doing something really meaningful. And so I feel very fortunate for the patient population that allows us to be a part of that experience. And then on the flip side of that, I also feel very fortunate to be a part of such a large care team. Amy was so kind earlier to say who supports the social worker. I do think that we draw strength from our interdisciplinary team. We see a wealth of knowledge, expertise, as well as just like true care for patients and families. And so I think that these are very meaningful positions. It can be very emotionally draining at times, which social workers also have to focus on self-care and sustainability. But I think just overall, globally, the daily resiliency and strength that we see is just what keeps us going, I would guess, for most of us.
That's beautiful. Thank you. I'm glad that you see that in people to keep going. And I think that speaks to who you are as a person, because not everyone can draw that in from everyone else. They have to see that and recognize that. So thank you. And I'm glad that you're in the role that you are, because it shows that you're the type of person that can see that, draw from that, and execute and advocate in the right way that you're meant to. So thank you for that. Corey Berman said, we as social workers offer care conferences for families that invite all members of a care team. So this can offer clarification on goals, plan of care, improve communication between providers and the family, and also between providers themselves, and sometimes help with the barriers to care. Is this something that you offer as well? Care conferences for families?
Yes, that is something that we are a part of and help facilitate and kind of drive the conversation in those care conferences. And I think it's always a helpful reminder for anyone on the care team to remember some of the power differentials that exist for patients and families when they are trying to advocate for their loved ones, knowing that there is this kind of balance that they are trying to achieve of, I want to be respectful. I don't want people to think I have too many questions or I'm not trusting of the team. But also, I think a big piece of our role is encouraging families. Like, you truly are the experts. Our medical professionals are brilliant and they know a lot. And the ins and outs of your loved one better than anybody else can. So yes, that's a great example. Another way that we can facilitate bringing everybody in the room together to make sure that communication is there, that there is some transparency, and just also having the recognition that sometimes we have to kind of own that there is that power differential, and leaving room and space for hopefully the walls to come down a bit as we build that trust.
Wonderfully said. As you build that trust, letting all the walls come down, full transparency as we build that trust. It's just so important. I could go off on a tangent, but Laura, I want to ask you the same question before we go into our Q&A for the last 5 minutes of the section. So if you wouldn't mind, Laura, please sharing with us the patient story that has impacted your career.
Yeah, I don't, it would be hard for me to kind of say one patient or one family in particular. But kind of collectively, I think what has really drawn me to this subspecialty into pediatrics, into hematology, oncology, immunohematology is the continuity of care that you get. We care for very sick, critically ill patients at times, but then we also get to see patients on the outpatient basis when they're doing better, and so kind of having that dynamic of seeing both critically ill and very sick patients, but then having the opportunity to see them outpatient, and build that relationship over a period of time and really get to know not only a patient, but their family and kind of their family dynamic. I think that it's such a difficult time with a rare diagnosis or a chronic illness. And I think as a care team, I always feel that it's a privilege to be able to be a part of someone's care team, and to have families allow you into their lives. And, I always again think of that as an opportunity and as a privilege, and very grateful that I'm able to be in that position and hopefully try to alleviate any stressors or some stressors that a lot of stressors that come in with rare diagnoses, and also trying to care for and figure out exactly what's going on with the loved one. So I really view it as a privilege, and kind of the continuity of care that we have kind of in this group of patients is why I'm drawn to it.
That's amazing. Thank you. Thank you, all of you, for sharing. Thank you all for coming on and speaking about your roles and the scope of that role, and meaningful interactions with patients. And after speaking with all of you, and I hope the rest of you on this call can attest, you are all the right people to be in the roles that you are. You all speak so highly. The motivation that you have behind your careers is amazing. And I'm just glad that you are all the people in front of the patients that need you and have that resource. So thank you all for being on the call. I do want to open up the floor for any questions you may have. Feel free to either put them in the chat, or you're more than welcome to turn on your video and open your mic, and we can have an open discussion right here. Again, thank you all. We have from everywhere, again, on this call. We have the University of Michigan. We have Vanderbilt University. Phil and Vanessa, you are from
University of Minnesota.
Minnesota.
Masonic.
Yes.
Yep.
Okay, great. So there was a lot of correlation between your universities, which is great, which shows that you're all providing an excellent level of care by having these different sources for patients and opportunities for patients. I don't see anything. Well, I might see. The Q&A box. Again, I can stop chatting at any time if anyone wants to unmute and then pop out. Or if you have questions for each other or questions for myself. Hello, Kristen.
Hey
How
guys,
are
good
you?
morning. Good morning. I really enjoyed hearing from Laura and Anna about their experiences in training and communication. And I think there's a lot of formal education as those of us in the medical field are going through training. But I can tell you, in my field, I think I have learned so much about communicating with families from our social workers and from those care conferences. We'll be having conferences over incredibly difficult discussions about end of life care, and other things that are hard for anybody, right? And our social workers are able to speak up and speak what the family may not be able to ask or say, and really bring the conversation where it needs to go. So I thank you guys for that. And I think that's such a critical role and so helpful.
Thank you, Kristen.
Thanks,
Are
Kristen.
there any times where you see a patient and you can just understand that they're overwhelmed and you just go, you should be asking me this right now. You should, these are, I want to make sure that you have a hold on this. Or is there I want to know which clinic may do this, or personally if you've done this. kind of given them in their summary a full detail? Is that a part of their patient portal? Is it a part of the after meeting summary? Is every note in there? Do you kind of notate things that you really feel are important that the patient should know, not just what you've overviewed, but kind of a little input for them as well?
Yeah, I was also when you mentioned earlier about interactions and having questions after the fact, I would really encourage patients and families, if you finish an appointment and you feel like you don't know what the next step is, or there's this question mark, like, wait, what are we doing exactly? Like, ask that, because there should be a follow-up plan, even if we don't know a diagnosis or we're working something up. There should be follow-up built in, and we have nurse coordinators as our care coordinators who would do a lot of that work. But you can tell sometimes when people are just like, I don't feel like this is a natural closure. Like, we haven't finished our conversation, but maybe there's no more information to share. There still needs to be that follow-up plan, right? Because there may be information coming back, or we need to see how things are going and check in again. But as patient and family, like, sometimes we rely on you to be the one to say, like, yeah, I don't get what's coming next, or like where we're going with this.
Yeah, and I think just from my observations, it seems like our team does a lot of like teach back and kind of like allowing the family to be a part of the care. And it really sets them up for success in the outpatient setting when they feel like I've had so many opportunities to practice these things in the hospital. And along with the support by my side, now I feel ready to kind of take charge and be the caregiver in that setting. So I think that's really critical too, is allowing them to have a voice on the care team as well. And I think time and time again, I hear families as one of the biggest things that they offer gratitude for is, these physicians, the doctors, they listen to me, they answer my questions. It's not just them kind of talking at me, it's with me. And I think that, with the care that goes into that, it helps set the patients and families up for a long-term success as well.
Absolutely. Everyone, Laura, Vanessa, Anna, Bill, Kristen, Amy, who left us, Nathan, thank you. All of you, thank you. It is that point in the day where we are going to take a short break before we go into our education sessions. So hang with us, grab a cup of coffee, fill up on your waters, and we will be back shortly. Thank you all again so much. Thank you for advocating for patients on all ends of the spectrum. And I hope that patients realize how valuable you are, put their trust into you, and really partner with you, because it takes a full care team to make a really impactful difference in everyone's lives and in the entire relationship. So thank you all very much. We'll see you shortly in about 7 minutes now. Thank you so much. Bye-bye. Hello, everyone. We're slowly welcoming everyone back for the 12:15 segment. So in just a few moments, we'll be getting started.
Welcome, Susie and Scott.
Thanks, Melissa.
Thank you.
All right, it is 12:15, so we can probably go ahead and get started. It's my pleasure to be able to introduce my colleague, Susie Reed. She's an associate professor at Nationwide Children's in pediatric hematology and oncology, and she was paired with Scott Maurer. Hopefully I'm saying your last name correctly, who is also an associate professor in peds hemonc at UPMC Children's Hospital of Pittsburgh. They're going to share with us breaking bad news in rare disease and their perspectives on that from education. It's very poignant that we had some conversations about this in some of the earlier sessions today, and so and how physicians may or may not get trained in these sorts of things. And so hopefully this is just one aspect of the way that we are able to help facilitate that for our trainees, but also for other staff members as well. Thank you very much, and I will leave it to you.
Thanks, Melissa. So as per our email this morning, can I share my slides or do you want me to use your slides?
Oh, yes, you can share your slides, hopefully. Sorry, I thought we got that squared away. Do you have permission? Perfect.
Awesome. Let me. All right. Well, I'm going to get us, started today. I do want to preemptively apologize. I have some sort of viral situation happening, so I'm a little huskier than usual. Anyway, and I think I can speak on behalf of Scott. I would like to thank the NICER Symposium for inviting us to give this talk to you guys, to you people here. I think that both of us feel very passionately about this topic, and we hope that we can share with you some of our perspectives and give you some tips to take home. So oftentimes, breaking bad news is a phrase that's commonly used, and as was indicated in Melissa's slide, introductory slide, we would like to change that to sharing serious news, which really encompasses more of the conversations that we have and really better encapsulates the kind of things that we talk about with our families. And certainly a lot of the news that we share is bad, sometimes the worst news that a family has ever heard, but we really think sharing serious news is a better framing for what we're about to talk about. So Melissa introduced a little bit of me, but I will just piggyback on that. So again, my name is Susie Reed, and I'm a pediatric oncologist at Nationwide Children's. And my medical education hat is as a pediatric residency associate program director. And I've been both of those things for 12-ish years. I am also a concert goer, and this picture in the corner is me with my 5- and 7-year-old at their first concert this summer, which was Kids Bop. So if you've ever experienced Kids Bop, then you know the true joy that accompanies it. So I'll let Scott introduce himself.
I don't know how to follow that, Susie. That's amazing. So I'm Scott, And actually, I have moved divisions since I accepted doing this talk. So I am now in our own division of pediatric palliative medicine and supportive care here at UPMC Children's Hospital Pittsburgh, but I'm also a pediatric oncologist and continue to do work with our pediatric oncology team. This is my family. We were in Ireland this summer, which is only slightly better than Kids Bop. I am a dog lover. That's my dog Iggy, and I also love to hike, and that is us on a hike. It's a good family event that we do together. And my email's down there at the bottom if anybody has any questions. But I'm really super excited to be here, and I also just want to thank the organizers of this conference for picking this topic because it's really, really important to everything that we do, but especially to this group. And so I'm really glad that there was time carved out for this topic. So thank you.
Thanks, Scott. So I'm going to get us going, and then about halfway through, Scott will take over and finish us out. So in true medical educator form, we have some goals and objectives for you that we hope that you'll take away from our session. So we hope that we can compel you to appreciate the value of communication in the patient experience and in our patient outcomes. And we also hope that we will be talking about and therefore you will be able to utilize a framework for effective and compassionate delivery of difficult news. You will note one thing that is not on this goals and objectives slide is that you will be a perfect communicator and never mess up or say the wrong thing or wish certain words hadn't escaped your mouth. So that is not our goal, nor is that the bar we hold ourselves to, even as people who've done this a lot. So I would like to start with having you take a look at this slide. So this is a collage. The title of the collage is called Chemo, and it was the cover art for the Dartmouth College of Medicine magazine several years ago. So I want you to take a look at this collage and unmute and share or pop in the chat what hand you think represents the physician's hand. So I'm going to count on Scott to look at the chat since I can't see it. If anyone feels brave enough to share their opinion on which hand is the doctor's hand.
We've had somebody say holding the needle. I would probably say that's probably true too. Top right, the pokey thing.
Anyone have any other opinions besides the hand holding the needle?
I wish it were the one getting the needle.
Well, to be honest, I have no idea if
the face palm.
Sorry. Oh, the face palm. There's a vote for the face palm. Great.
Yeah.
To be perfectly honest, I have no idea if any of these hands represent a physician's hand. I don't know what the artist was thinking or meaning when they were creating this art, but I love it because I think it really encapsulates our very difficult roles as physicians and as healthcare professionals. So I think that to me, the hand with a needle, I do think it's a needle, represents that we do things to patients. So we poke them, we do labs, we order scans, we give treatments, we do BMT, we do all of these things to patients. But we also are listeners, and we are providers of compassion. And I think that center hand really represents our role as emotional support for our patients. And I think I'm glad that at least some person voted for the face palm, because what that says to me about our role is that we are people, and that we are people who have whatever baggage we have. We have good days and bad days, and we have kids that are getting bullied at school, and we have health concerns of our own, and we have all of these things about ourselves. We are people who experience suffering as well, and we bring that to the table because we can't not bring that to the table when we talk to our patients. And so I think that this, to me, this really reflects how difficult and complex our jobs are.
And Susie, another person said, I always feel like the statue in distress, which I think fits nicely with what you just said.
Yeah, yeah. And that's okay. We're people. We have distress, and we shouldn't be held to a different standard than other people. So shifting gears just a little bit, kind of getting us into the headspace of what we're going to be talking about today. I'd like you to think of a time when you learned sad or difficult news as a patient or a family member, not as a healthcare provider, but as a patient or family member. And I want you to think about things that were helpful to you. So I'm hopeful that this will work. So I can't, ooh, shoot, hold on. Scott, are you seeing a QR code in the corner? Is there a QR code?
I am not seeing the QR code.
Oh, nuts. Oh man, I was, okay. Instructions.
There it is. There it is.
Okay. So I thought I did do a dry run of this. So if you could scan this QR code and think about the things that were helpful to you when you were hearing difficult news in the healthcare setting. So then I'm going to like pop over to response. Okay, I'm going to go back to this QR code. When I was practicing this, the QR code was up in the corner, so you could see both the responses and the QR code at the same time. So I'm going to scooch over to responses. Oh, it's over there. There it is. It's people are saying things, and why is it over there? I see people saying stuff. I don't know why that it's not able to be seen. Let me see if I can figure this out. I'm going to, oh shoot. Well, I am sorry. I don't know why the responses are not visible on the screen, but thank you for sharing. I think that thinking about your own experiences in the healthcare setting and thinking about things that were helpful to you can be really powerful when thinking about how we are sharing this kind of news with our patients. So we are going to talk a little bit about some of the evidence behind communication skills with our families. So while this talk is specifically about sharing serious news, there's actually a lot of work that has been done about basic communication skills in every setting. So what do our patients want? So I will warn you that this list is, while will probably make a lot of sense to you, some of these things are a lot harder than they might seem. So, and that these themes of what patients desire in their communication with their physician and in their healthcare team are consistent throughout a lot of literature. So uninterrupted face-to-face communication, clear and honest communication, information given in understandable terms. There's a variety of health literacy levels in our patients, we know that, and emotional support and time to ask questions. Easy, right? So easy, just to give all those things to all of our patients at all the times. So in thinking about communication within the medical climate, our very complex medical climate. So there's a lot of things happening at the same time. So we have patients with complex diagnoses, and certainly in the sphere of rare diseases, quite complex and rare diseases, and which leads to difficult decision making for families. We are appropriately expected to be sensitive to patients' and families' needs, to be aware of our own emotional selves, And we also have to consider that our families have, you know, increasingly more access to information, both good and bad. And this all factors into a extremely complex healthcare climate that we are navigating, it both in the care of our patient and the communication setting. So it's a lot to balance at times, or all the time. And sometimes we drop things because it's hard. So even though it's hard, building trust is a really important foundation for any kind of conversations or communication that we have with our families. It's even more important when we are sharing serious news. So this is also hard, but again, a step that we can't overlook. So if there's building trust can be hard for all of us. It can be extra hard if there's any learners on the Zoom session. You know, students and residents feel an extra special difficulty in building trust when they are not seen as the experts. It's also difficult sometimes when people like, you know, Scott, as a palliative care physician, being called in at a really critical time, and it may be the first time he's meeting a family and talking about some really hard things. So building trust is a step that cannot be overlooked. Building trust is difficult because we don't always know the answers to questions. Even when we're experts in our field, we still don't know a lot of answers. There's a lot of opinions in our job, and our families may be being told or hearing different things from different people, which is confusing, and that can really erode at trust as well. And we are in an environment that things don't happen as planned, right? A kid's supposed to go for a procedure at 9 a.m. and now here it is 3 p.m. and it's a crying 3-year-old who's hungry and they're an add-on in the operating room. And again, while it may seem like a sliver in terms of the impact on a child's care, that sort of feeling from the patient that something was supposed to happen at a certain time and that didn't happen, that those things really chip at patients' trust in us. And also medicine is ambiguous. You know, even when we know answers, there are oftentimes many different correct answers to a lot of questions, which all of that can affect how we build trust with our patients. So even though patients expect a lot of us, and even though it's hard to remember all of the things they want, and there are a lot of barriers to building trust, effective communication really matters, not just because we're nice. I mean, we're nice people. Scott's really nice. And even though we're nice, there are actually tangible outcomes that good communication provides for our patients, besides it being the right thing to do. So effective communication leads to better health outcomes. It leads our patients to have better compliance, more active self-management, which is related to compliance, and improved patient satisfaction. And again, this really sets the stage, especially when you're first meeting a patient or when you're delivering or discussing serious news, that really sets the stage for the rest of your relationship with a patient, even if it's just for a shift. So when the news is bad, and again, like we've already established, some news is like unquestionably bad news. All of the basic communication skills, clear communication, providing emotional support, building trust, and having compassion and empathy, all of those communication fundamentals are even more important. So when we're delivering serious news, what might we have to navigate? There is a lot. All of these kinds of responses and emotions as a result of discussing serious news with families are all okay and reasonable and fair. Everyone responds to these situations differently. And so all of these are on the table, and we have to be ready to give space and accept all of them. So I did want to make a quick comment about special populations, special to us as pediatricians. So when we think about our patients, we as pediatricians, when pediatricians are managing their patient, the patient is just one part of the whole dynamic. We have obviously the parents or caregivers are critical to the care team. And so besides the general communication things that we've already discussed that patients want from their physicians, so parents want to be actively involved in the decisions for their children. Parents also want help with discussing difficult news with their children. Again, this is something that Melissa alluded to at the beginning. There's not consistent training on delivering or discussing serious news in the medical field. So a lot of physicians might not feel prepared to be having these conversations. And certainly a lot of parents and caregivers feel underprepared to be having these difficult conversations. Parents want to plan, and parents want to be mindful of not having their children feel like their children are on display, and difficult conversations to be had in small groups. So another special population, if anyone has an adolescent at home, if you're a parent to an adolescent, you perhaps also feel like they're a special population. My kids are still young, but I'm trying to imagine that day coming. But adolescents are special in a lot of ways regarding communication because they're not babies, they're not kids, and their frontal lobes are not fully developed. So they require a little bit of nuanced care as well. So adolescents want direct involvement in their care. They don't want to be spoken to like babies. They want the article that this is from and some of the other articles related to adolescent preferences talk about excess empathy. They don't want excess empathy for them because I think it makes them feel spoken down to. They also want acknowledgement of their lives as teenagers, and their lives as teenagers means their social support networks are a really high priority for them. And they also want us as physicians to recognize that sometimes they don't want to talk, and we need to be sensitive to that and be looking for those signals that now is not a good time for them to talk, so that we can get the most from them as people being directly involved in their care. Oopsie, sorry. So a lot to think about as we've talked about. So we've discussed some of the layers of communication in the healthcare system, but I do think it's very important to say that no one way is always right, and you will not get it right every time, as was mentioned before. Even people who do this on a regular basis, who have these difficult conversations on a regular basis, may feel a little more comfortable doing it, but we won't get it right every time. However, approaching your conversations with a structure can help increase the chances that you will create a communication experience that is safe and lands well with a family. So we're going to talk about a communication structure, one of several, that can really help the conversation go as smoothly as it can. So we're going to talk about thinking about delivering or discussing serious news in 3 phases. So there's the preparation for the conversation, the delivery of the news, whatever you're trying to say, and then the wrap up. So to start us off, in thinking about preparing yourself, the first step is gathering your resources. And that might mean a lot of things depending on what kind of conversation you're about to have. But certainly preparing yourself by making sure things like, whoever needs to be in the room is in the room. So if you go see a patient and there's one adult there, one parent there, and by themselves, then maybe you want to ask, is there anyone else here at the hospital? Maybe dad is down getting lunch or something, or maybe there's another family member that could be there that would provide support to an adult that's by themselves caring for a child. So whether it's preparing yourself with making sure the people are there, making sure there's enough chairs and tissues and those kind of things. Additionally, making sure you're prepared with questions that the answers to questions that you can predict that families might ask. So meaning that if you're, disclosing a diagnosis of a tumor, it may not matter to you as a physician how large the tumor is, whether it's 6 centimeters or 7 centimeters or 8 centimeters, because it's the same regardless. Those numbers may be the same to you, but parents will ask those kind of things and families will ask those kind of things. And trying to predict what kind of questions they will having answers for them will again goes a long way in building trust. So making sure you are prepared and making sure you are in the right headspace to have the conversation, whether that's taking a minute outside the door to take a deep breath or just think about, how am I going to have this conversation? Like, what's my structure? What's my goal? Those kind of things. Preparing yourself is a really important step. All right, I'm going to pass it to Scott.
Awesome. So I'm going to talk about some of the other steps that we can follow for a framework of how to be really effective communicators. And the one that I want to talk about is delivery. So that was the next on the map that we have there. And thinking next slide about a skill that we have that is called ask, tell, ask. And what I'm hoping I can do is you can leave here with this little tool in your tool belt that you can think about the next time you have to give somebody serious news. The reason why ask, tell, ask is something that's very effective is because it basically forces two-way communication. Because you're asking open-ended questions, you are ceding control of the conversation to the parent or to the patient or to the learner. And when you do that, you give an element of control to that person, and it reduces the overall level of stress that a person might feel in a very vulnerable position. And so the first part of ask, tell, ask is one, we want to ask the patient what their understanding is. Can you go back, Susie? We want to ask the patient what their understanding is so that we can assess that. We want to tell them the information, and then we want to check for understanding. So ask first understanding, tell the information, and then ask for understanding at the end. All right, cool. Thanks, Susie. So the first thing we want to do is that first ask. And this is a really great way to start a difficult conversation. A lot of times people are like, how do I even start this? Do I just blurt out like what's going on, or how do I do this? And what I always say is, let's start by asking a question. So what have the doctors told you is a great example. Just to make sure that we're on the same page. Can you tell me what the other doctors have said to you? Oftentimes I'll preempt this because you don't want to go in the room and be like, what has everybody told you? Like you haven't like prepared or read the chart or whatever. I always say, I've read the chart and I've talked to all of the other doctors that are involved. I guess what I'm really interested in is what have you heard them say? Or what have they told you? And that gives me a sense of where we are. Either the parent already knows the information and now that kind of lets the air out of the balloon for the rest of the time, because then we can just move on for a more cognitive conversation, or it might tell me that they really don't have any idea what's going on or something in between. The other thing is to ask permission. I realize I didn't say ask, tell, but I always want to ask permission. Is it all right if we talk about the situation that we're in here? One thing that I do as an oncologist is I'll say, hey, I've had a chance to look at the scans. Is it okay if we sit down and talk about the results? Some people might call this a warning shot. And in a sense, it is a warning shot because you're saying, hey, I have some information. I'd like to share it with you. Is it okay if I sit down? That's a clue that you're about to tell somebody something important. And it's different than when you say, hey, I've got some bad news. If you come in and use a warning shot of, hey, I've got some bad news, that's not a warning shot. You just shot them, right? Emotions are going to go through the roof and they're not going to hear what you have to say after that. And so what I like to do is I just say, hey, I had a chance to look at the lab work that came back. Would it be okay if we sat down and talked about it? That sets the stage that the parent is like, okay, I'm going to be told something important. So that's the first ask. Let's go to the next one. We talked a little bit, I just talked a little bit about foreshadowing. There's some serious things that we need to discuss. The other thing I want to say is when we give news, and the reason why ask, tell, ask is super effective because it builds in those breaks. We want to give news in small chunks. So if you're discussing a diagnosis of severe aplastic anemia or Diamond-Blackfan anemia or dyskeratosis congenita, these are really complicated things. Severe combined immunodeficiency, it's complicated. And so you've got a lot of information to give. And what I'll say is when we have a good day at the beach, it's a day where the waves come in and the waves go out. And the waves come in and the waves go out. A bad day at the beach is when there's a tsunami. And it's just a flood of information that's coming towards a parent or a patient, and they get really overwhelmed. And so what you want to do is, the biggest thing I can say is use silence and stop talking. And when you do that, you are sending a message that I am ready to listen to you. I am expecting you to have a reaction to this, and I am here to listen to what that reaction is. It also cedes control of the conversation back to the parent or to the patient. And when you do that, it brings anxiety down. It also helps you because if you've just given bad information, you're like, oh God, where do I go next? It gives you space and gives you some space to actually say, hey, I got a little time out here. I got a little breather. I can plan for what to do next. Next slide, please. So when we get to, I want to talk a little bit about the tell. When we get to the point where we have to tell, I want you to think about it like a newspaper article. And I want you to give it in headline form. So headline, just advance it. Headline form has several components. And what we want to think about is when we give a good headline, we want to give information and we want to give meaning. And so some headlines are better. Amphibious pitcher makes debut. Obviously, that headline could have gone better. So we wanted to practice our headline beforehand. And so I still do this. When I have to go give somebody serious news, I actually write down my headline before I walk in the room. When I'm with a learner, when I'm with a fellow or a resident or a medical student, I say, hey, we've got to give some serious news here. What is your headline? And we pause outside of the room, we take a minute and we write a 1 or 2 at most sentence headline. And we practice it. And I have the learner write it down. And then I say, all right, you're going to deliver this headline and then you're going to stop talking. And I'm going to give you feedback on it when we leave here. Okay. You want to practice this headline outside. So here's an example of a headline. Your son's bone marrow is not making enough platelets or red or white blood cells. We need to do a bone marrow test to learn more about what's going on. So this headline has information. Your son's bone marrow is not working. We will need to do and it has meaning. We will need to do a bone marrow test in order to figure out what's going on. It means I don't have the answer for you right now, but this is the next step. It's a plan. It's the next step to move forward. And then I'm going to stop talking. Susie, if you advance it again, there should be another one. Yeah. The pathology report shows that the lesions in your daughter's spine are called Langerhans cell histiocytosis, and she will require chemotherapy to treat it. This has information. There is a name to what is going on and meaning. We're going to need chemotherapy to treat it. This is big news, right? And so when you deliver it, you're going to stop talking. And when you stop talking, we'll talk about what happens next. But before we do that, I was hoping that maybe we could practice it. And so on the next slide, there's going to be a case. And we're going to read this. I'm going to read it to you. And then what I want all of you to do right now is go down to your little thing and open up the chat so that it should appear on the right-hand side of your screen. And I do not want you to type anything. Okay, I'm going to read the case and then I'll give you instructions. Okay, so we have a 12-year-old boy who was seen 2 days ago in hematology clinic with a 2-month history of abnormal CBCs that the PCP was following and hoping was viral suppression. You examine the kid. The physical exam is pretty normal, except for some scattered petechiae and maybe some pallor, but there's no limb or bone skeletal abnormalities that are very obvious. There's no stigmata of a bone marrow failure syndrome. On a CBC that you did, the white blood cell count is 1.8 with an ANC of 200. The platelets are 15. The hemoglobin is 7.5. There's an absolute retic count of 15,000, and the MCV is high at 104. Next slide. So you're worried about this little dude, and so you admit them for bone marrow evaluation and also monitoring because you're worried about the counts. So 2 days later, the bone marrow comes back and shows that there's 15% cellularity with marked suppression of all cell lines. Flow cytometry was done and is negative for leukemia or myelodysplasia. You, like a good physician that treats this sort of thing, have sent all of the right tests, right? You've sent cytogenetics, you've sent chromosomal breakage studies, all that testing is pending. There's no family history of bone marrow failure, and this kid, you hit the jackpot. They have 4 full siblings. What? Always a good feeling, right? So you are meeting with the family to discuss his diagnosis. You ask the family what they've been told, and they say, the doctor yesterday said that it's not leukemia, but that his bone marrow might be messed up. Okay? So that's what you're working with. And what I want you guys to do in the chat is I want you to write out a headline. And we're gonna give 4 or 5 minutes to do this. And I want you to write out the headline that you might give in this situation that has information and meaning. And I don't want you to hit enter. I want you to just type it and then take a breather, okay? So I'm gonna give 4 minutes. We'll do this at 12:55, where I'm gonna have you all hit enter at the same time, okay? So type out your headline and I'll tell you when to hit enter. All right, team. I'm going to give just a few more seconds. I'm practicing that ever-present skill of silence, which is always a little awkward. I appreciate everybody for hanging in there with me. I'm also realizing that this is probably a familiar case to a lot of the immunohematologists that are here, but I'm also realizing that some of the allergists and immunologists may be less familiar with this diagnosis. So it's okay if you don't have a good headline for this, and hopefully we'll get a couple of good examples. All right. So everybody who was brave and put in a headline, go ahead and hit enter. All right. Perfect. Cool. So I'm going to read them and share. Okay. So my good friend Stephen Allen has said, yes, you are correct. Nice. You start out with agreeing with them. The bone marrow shows signs that it is not making enough blood cells. There's information, which we will need to follow closely. We have sent testing to assess possible reasons for why this may be happening, but those are not back yet. Information and meaning. Beautiful. Beautiful. Kristen, your son's bone marrow is not making enough red blood cells, white blood cells, or platelets. This is not leukemia, but something called bone marrow failure. Additional testing was sent to help us determine the best way to treat him and may require medications or a new bone marrow. Beautiful. Yes, Kristen, you have information, you have meaning, and it is short. And then beautiful. Gorgeous. Kara is telling us the tests so far show your son's bone marrow isn't working very well and might need medicine to make it better or a bone marrow transplant. Simple. It's one sentence. It has information and it has meaning. And often I'm a very wordy person too. So often what I'll do is I'll write out a headline and then I'll edit. I am when I have to write an academic paper, my first draft is a mess because it's way over the word count, right? And so taking the time to edit it down and make it so that it's in 1 or 2 sentences is perfect. Those are 3 really great headline examples. And now I get to delete mine because I don't have to do it because you guys did it for me. These are 3 really beautiful headlines. And if you go in and deliver this succinctly, then you can only go to good places from here. You're still giving serious news, and it's still news that is going to be upsetting. You can't change that, but you can change how you deliver it, right? Okay, let's move on. Thank you for playing along. So what I want to do now is we've talked about the delivery of this information. We've educated, we can talk about verifying. I want to talk about wrapping up. And the next step is really thinking about giving some space. And so next slide. So when you give somebody news that is serious or bad, or you might even think, gosh, I haven't really given them all that bad of news. It might even be good news or mixed news. The thing that is likely to follow is an emotional response. And so what I want you to do when you deliver serious news and you deliver that headline, the first thing you do is stop talking. And then I want your brain to start expecting an emotional response. When I hear something that is unusual or shocking or sad or disturbing to me, I am not in the cortex of my brain, right? I am in my amygdala and limbic system. I am going to respond with emotion. And this is normal. And when somebody responds emotionally to your headline, it means that it landed. It means they heard it. It would be really weird if I just told a family that their child might need a bone marrow transplant and they were like, should we start testing his siblings now? That would be strange, right? If they said, what? How could this have possibly happened? A bone marrow transplant? That would be more along the lines of what you would expect. Or they might say, oh, a stupid primary care doctor. We were watching this for 2 months and now he needs a bone marrow transplant and we've just been out in the world for 2 months. That's a normal response, right? And one that we need to respond to. The other thing I want to point out is sometimes it will be with words and sometimes the emotional response will come with body language. They might stand up, They might start pacing. They might not make eye contact with you or make very serious eye contact with you, which is always creepy for me. And so all of those things are appropriate and how you might respond. So let's talk about, if I'm thinking about the brain as a radio, where AM frequency is, I'm going to give you more information and I'm going to be very cognitive. And FM frequency is like rock and roll. I need to respond on FM frequency if someone is on FM frequency. If I respond with AM frequency, if they say something like, oh my gosh, how could this have possibly happened? This is not the time for me to talk about, well, it could be dyskeratosis congenita or some other inherited thing, or it could be just idiopathic, which just means that we don't really know why it happened. We think it's an autoimmune thing. Like, that is not the time to go cognitive on them, right? They're just going to escalate their emotional response when you do that. You want to respond to an emotion with an emotion. So next slide. So the thing that we do is we want to stop talking and respond with emotion and avoid that temptation to explain. Next slide. And the way that we do that is with this mnemonic called NURSE. And if I teach you nothing else today, ask, tell, ask, and NURSE are the things that I want you to take away from my portion of the talk. NURSE is a way to respond to emotion with emotion. And so you don't have to do all of these things. You do not have to go in order. I usually pick an emotional response that I think makes sense. So one response is to name that emotion. So if someone says, I just can't believe this is happening, I would say, this is really hard, or this is really unimaginable. Or I might say, this is not what you were expecting me to say. Right? An understanding statement is one, it's a sort of a misnomer. It's sort of saying like, there's no way you could possibly understand. I can't even imagine what it must be like to hear me say those words. I can't even imagine what you're going through. I try real hard not to say, I understand that this is stressful. Because do I? Even if I've been through a similar experience, the way that my brain reacts to that experience and the way the other person's brain reacts to that experience might be completely different. So I really, as much as I try to be empathic and I try to hone those skills of empathy, part of being empathic is realizing that you really couldn't possibly understand what it's like to hear those words. A respect statement is something I use when I'm talking more along the lines of something we can't fix. You've always been such a strong advocate for your child. You've always been there for your child. You're a good parent to your child. Those are respect statements. A support statement is, no matter what, I'm going to be here to help you. I can't make you a lot of promises, but what I can tell you is we're going to take very good care of your baby. Those are support statements. And sometimes you get a response that you're just not quite sure what to do with. Sometimes they don't say anything. They're just silent. And you like, I've been really good about giving silence, and you're feeling really good about yourself. And then it goes on way too long and you're like, uh-oh. Sometimes I'll just say, can you tell me more about what you're thinking? Or they might say something off the wall. Like you tell them the headline that they have bone marrow failure and they might need a bone marrow transplant. And they say, I knew we shouldn't have moved to that new house. And I'll be like, ooh, I don't really know what to do with that. So I'd be like, can you tell me more about what you mean when you said you shouldn't have moved? And then they might go into, oh, it's just that there's a chemical plant nearby and this is probably why my child has this. Oh, okay. I had that happen once. I was like, I don't really know. Okay. So an explore statement can get you out of trouble. If you really don't know what to do next, you'd be like, can you tell me more about what you're thinking? Or it's just a really good way to dig yourself out of trouble. Next slide. So the next thing is that ask, and this kind of goes back to that verify that we were talking about in our compass. And this is just verifying the understanding. So after you've given serious news, you want to know, like, did it land? Chances are, if you got an emotional response, it did land. And so one thing I say is, we've talked about a lot of really heavy things. What is the things that you're going to take away from this discussion? When you go home and tell your husband about this, what will you tell him that we talked about? And then the other thing is I like to assume that they have questions. So instead of saying, instead of saying, do you have any questions? If you say, what questions do you have? That implies you're sending a signal to them that this is not a conversation ender. Do you have any questions? Is a conversation ender, right? That means like, I'm getting ready to leave. So anything else before I go? When you say, what questions do you have? That implies that it's okay to ask questions and that you're expecting questions, right? And if they say, gosh, I don't have any, and be like, that's okay. This is really overwhelming. More questions are going to come. Write them down and I'll come back. But this is that verify to make sure that they really understood what you were saying. All right, next slide. So I want to talk about wrap up. That was our last step in our communication compass. And what I want you to realize is that the family or the patient, they may not be ready to move on to planning. Susie very nicely said that parents and research have told us they want a plan, and they do. They might not want it right after you've delivered serious news, and that's okay. Rome wasn't built in a day, and we're not going to figure out how to solve severe aplastic anemia in a day, right? We're going to have to get some more tests. We're going to have to, screen these SIBs. We're going to have to do a lot of stuff. So signs that a family is ready to move to next steps is if the emotional temperature in the room decreases. If they say something like, okay, what's next? That's a good sign. And I'll often ask for permission. I'm hearing you ask about what's next. Is it okay if I talk about what we're going to do for the rest of the day and into tomorrow? Is it okay if I move forward and talk about the plan or options? I was asked permission before moving on because they might be like, I can't even think about this right now. I'm like, whoa, still on FM frequency, right? If they're like, no, yeah, I really want to know, what are we going to do next? Then I'm going to move on. And then I'm going to switch to AM frequency. And again, I'm going to give small chunks because I might then say, so they might say, what's next? You mentioned a bone marrow transplant. Is that something we have to do? Who might be his donor? I'll be like, well, that's a good question. Is it okay if I talk about that? The first people we would look to are his 4 siblings. And they might then say, what? You need to test his siblings? Oh, you were in cognitive space, and now we've given another chunk of news. Like, oh my gosh, this is going to affect my other children. I didn't even fathom that. Now we're back in emotional. You're going to have to go back and respond to emotion, right? And so you can swing in and out of AM and FM frequency, and that's okay. It means that you're making progress, right? Okay, next slide. So these are the take-home points. When you have to give serious news, a skill that can help you give that news is to ask the patient or the family's understanding and get permission before giving the news. Tell your news in a headline form: information and meaning. Expect that there will be an emotional reaction and that you're going to have to respond to that with those nurse skills we talked about, and ask a patient or a parent's understanding and encourage them to ask questions. All right. So now my turn and Susie's turn to say, what questions do you have? And thank you for your attention. I really appreciate it. And this space and this forum to talk about it with people who are doing really difficult work.
Yeah, I share what Scott said. We intentionally left a little bit of time at the end just for questions and open conversation.
And if you feel more comfortable putting stuff in the chat, go ahead and put stuff in the chat. I know it can be intimidating in a large group to unmic.
Hey, Scott, I have a question. And Susie,
Yeah.
thank you so much for the great talk. I really, really appreciate your insight. And I've found you to be a really invaluable resource, Scott, at Children's. I struggle with keeping my own emotions in check, like feeling like I'm going to cry, giving bad news. And thankfully, it's allergist and immunologist, that's far less common than an oncologist, but it's devastating when it is. And I was wondering if you had tips for trying to keep your own emotions in check and not derail it, so that they're like trying to obviously comfort you or being even more weirded out by the fact that you're feeling distressed.
Susie, you want to take that, or you want me to?
I'll comment and you can comment. I think that I think some of it depends on your relationship with the family and what you're talking about. Because I think emotion is acceptable. We're all humans, and like it would be like unfair to be like, just keep it bottled up, save that for your therapist, you know, like, and just plow through. That's not compassionate care delivery. So I will comment that I think if you are meeting a new family or a new-ish family that you don't have an established relationship, disclosing a very serious diagnosis, then probably less overt emotion is probably what you aim for. And if you feel like, as you're preparing yourself, you know, like the first step in the conversation is gathering your resources and preparing yourself. And if you feel like you're not in a mental space to have that conversation, then don't have it. Then take a break, or like, you know, sort of whatever that you need to compose yourself. I think that when I think about some of my patients, if I have had a long relationship with them and perhaps they're transitioning to comfort care, or there's some sort of, I'm having a difficult conversation with the family that I know very well, and with a child that I love, then I feel like emotion is okay and it's normal, and it feels authentic to the family that you love their kid.
I think the thing that I would add to that is this harkens me back to Kristen's response to the picture, the photo that was shown earlier, which is I feel like the person who is sort of overwhelmed, the statue that's in distress, and we're human beings, and this requires us to do this job. We need some self-care here. And one way that you can help with your own emotional response to it is, 1, recognize that it's okay. 2, lean into it. And 3, talk to your colleagues about it, right? I had to go in and tell a patient that his AML had relapsed. I was devastated, loved this kid, knew what this meant for him. He was super excited. It was the start of the school year. He was going to play football again. He was super excited about it. I was just, I took a look at the CBC and was not expecting it. I know that he wasn't expecting it. I was just devastated. I actually did not go in the room. I sat down with a colleague and I talked it out. And I actually got my own emotions out first, calmed myself down, and then went in the room. And it was still hard for me, and I still cried like a baby in front of him, and it was totally fine because I knew him and it meant that I cared. But I knew that I wasn't in a good space to do that, and I leaned on my colleagues, because at the end of the day, your colleagues know what this feels like, and they are a great resource for you as you think about navigating your own emotions to when something just doesn't go well with one of your patients. My wife is not in medicine. And so for me to go home and tell her about dying children, she's like, stop, don't want to hear it. That was your choice, not mine, right? And so I really do lean on my colleagues, and it's okay. We have to be there for each other. Christopher has put in the chat, part of these discussions could contain giving family information on patient groups like race, IDF, etc. Yes. So meaning, Chris, are you Chris or Christopher? Sorry, I don't mean to assume that you shorten your name. Are you able to elaborate on that a little bit?
Hi, folks. Yeah, I've got you on like 3 different screens, so I'm trying to figure out where everyone is. So thanks for indulging me. So, as we're talking about, it's a deep emotional journey for these families. A lot of times, the information that's given, and this was a really great talk and really encouraging. It is difficult for the parents to comprehend, and even at the moment, if you think they're getting it, you're going to have a lot of questions, a lot of other things, and as compassionate, as great as you folks are, you only have so much time. That's why groups like Race and IDF and other patient groups have a lot of resources, whether it's peer support and counseling, whether it's medical information that's explained as best as you can for directed at families and those affected by these diseases. That's in a, as best you can, much more plain, simple English format. And once people are connected and they're given the opportunity to learn how to be better advocates for themselves, how to navigate this by learning from resources of others, I think both the emotional and the physical journey becomes a little bit easier. So I think the patient groups have a good part to play in that. And certainly referrals from groups like yourselves to our foundations to help the community and the patients go through this, I think is a decent part of this process.
Amen, brother. I think what I would tack on to that is I think what I'm hearing you say is know your resources. And as the clinician, it's really important to know when it's appropriate to refer to those resources, right? They may not be ready for it on day one. Once the initial shock is over and they're in a more cognitive space, I agree with you. Like leaning on those resources that we have makes a ton of sense. Susie, I don't know if you have anything to add.
Yeah, no, I agree. I think most of, I think a lot of our patients, in the oncology world are a part of those sort of support groups, for lack of a better word. But I do think, to your point, if there's only so much time that you have, and if a patient's in the hospital, yes, you can go back to their room, but a lot of these questions come in the middle of the night when the kid is outpatient and the mom can't sleep because she's worried about 10 different things. And I think that there is a lot of relief that can come with sharing stories among families going through this, for families who are going through related journeys. Totally agree.
Yeah, and I think the other thing I would add to that, there's kind of epiphany, is when we care for families of children with serious illness, it's a team dynamic, and there are some physicians that I work with who are like, listen, I am really good at understanding how T cells work. I am less good at responding to emotion, right? That's why we work on interdisciplinary care teams, right? You have a lot of the hospitals that are represented in this consortium have music therapists, art therapists, psychologists. Like, it is okay to lean on those resources. It's also great to use these communication skills to give information clearly, but it's also okay if you're not necessarily equipped to help them navigate all of the emotional stuff that goes through this. Using your resources in your team is really a really important skill to have. And being okay with that. Like, you don't have to do it all. Awesome, guys.
Well, thanks so much to the both of you. I think everybody who was here really got a lot out of this. I know that you had left your email addresses, so if people do have other questions or things, they can reach out directly, and certainly know where those resources might be at their institution as well, is always very helpful.
Oh, there's my email address. You'd think I'd be better at Zoom, like, by now. And there's, Scott's is very small, but
very small. Sorry.
I'm okay.
Thanks, everybody.
Thank you, everyone. We really appreciate your willingness to share in our discussion, both throughout the session and then at the end. Oh my gosh, you guys, I'm the worst. Okay, there's me.
Take care.
Nationwide.
Thanks for joining us.
Yep.
Have a great day.
Thanks again, Melissa.
Well, hopefully we'll see some of you back here in the next couple of days.